Good afternoon, good morning, and good evening to all of you who are joining us from anywhere in the world. We are very happy to have you all with us today. This is our 8th session of AI for Public Health. And we are glad to have another great speaker with us this afternoon with Dr. Blessing, who will be moderating this session. Dr. Blessing is a postdoctoral fellow with York University. He has over 15 years of combined professional experience across a broad range of fields in academia, industry, and community-based organization. He has been with York for a couple of years now, and he has been moderating this session for the past few months now. Thank you very much, Dr. Blessing, for taking the time and moderating all these sessions. And with that, I'm going to give the floor to you to introduce our speaker for today, and looking forward to great conversation among the speaker and also all the participants. Thank you very much again for joining us. Dr. Blessing, floor is yours. Thanks.
All right. Thank you very much, Professor Ali, for introducing me, and welcome our audience all over the world. Today, we are going to have our speaker, Barrister Okechukwu, Effoduh, who's going to talk to us today. Permit me to introduce Barrister Jack. Barrister Jack is the Chief Counsel and Councillor of the African Canada Artificial Intelligence and Data Innovation Consortium, ACADIC. He is an experienced lawyer with expertise in human rights, emerging technologies, and artificial intelligence. He has worked in over 30 African countries and demonstrates a history of working across various national, regional, and international legal institutions. He is a Venier Scholar at the Osgood Hall Law School of York University and serves as the Global Future Council on Frontier Risk, a brain trust of the World Economic Forum. May we please welcome the Professor Barrister Jack Okechukwu Effoduh. Thank you.
Thank you very much, Dr. Blessing. I'm really happy to connect with the 8th edition of this really powerful webinar series. And thanks, Professor Ali, as well as Professor Jude, for the great work you've done. I'm really excited and happy to be engaging you all at this AI for Global Health Challenges and Lessons Learned bi-weekly webinar series. Of course, there is none other platform than this to discuss on issues around the use of AI in the Global South. So thanks to ACADIC, thanks to the Global South AI for PEP, and all the other co-partners, I think IDRC, York University, CFAL, UNITAR. It's a great pleasure. And thanks, Blessing, for the introduction. I'm very grateful. I think you all have put together such a great series by providing a free public platform for very important discussions that even if you ask us to pay, I don't think participants will be able to afford it. But thanks for this platform. And today we will discuss how to tackle bias in health AI systems from a regulatory point of view, from a law and a human rights lens. And so I would present for about 50 minutes, and then we have about maybe 15 to 20 minutes to discuss. For me, this is not going to be like a lecture, but it will be like an engagement. So more like a conversation, right? So feel free to contribute, use the chat box, share your links, ideas, and of course, bring in your questions. You don't have to be politically correct. I think when we talk about regulating bias in health AI systems, it's still a nascent and very new area of discourse. So I will try to go as simplistic as possible, not to undermine the intelligence of the participants, but I want to ensure that I'm picking everyone from the ground up. So I will go very basic sometimes, and then if it's too basic or anything that is not clear, please do let me know. If everything is okay, I would like to start with an introduction. Is that okay, Dr. Blessing?
Yes. Do you want to share your screen?
Oh, great. Yes, let me share my screen. Please let me know if you can see this.
Yes, we can see it. I can see it.
Okay, right. Let me see, just to be sure that everything is moving. Okay, great. So you can see my screen, right?
Mm-hmm.
Okay, fine. I can't see it, but it's fine. As long as you can see it, I'll just move that. So, well, we're talking about regulating bias in health AI systems. And as an introduction, what I would say is we all know fully well from the 7 episodes we've seen so far that the healthcare industry is witnessing an era of innovation explosion, part of which is as a result of the increasing use of artificial intelligence within healthcare context. So although artificial intelligence is still relatively new, we've seen very many promising examples of AI systems that are improving diagnostics, treatment, increasing the speed of healthcare delivery. For example, there are AI systems that are remarkably predicting disease outbreaks, cancers, heart diseases. Even AI for PEP or like ACADIC has shown you the use of big data techniques to be able to predict global health challenges like monkeypox, like COVID, and the rest of that. So the use of AI is pretty much advancing the practice of a wide gamut of healthcare, from telemedicine to medical informatics to improving clinical operations, name it, right? So many of these innovations are still unprecedented. Like, it's never been done before. In the last 5-6 years, we're seeing the use of AI in healthcare that was just never thought about before. However, one of the biggest challenges, in fact, what I would consider the biggest challenge in the use of AI for healthcare, is the issue of bias. And when we talk about bias in this field, we're referring to instances where the application of an AI algorithm on an AI system gets to compound existing inequities, be it in socioeconomic status or race or ethnic background or religion, gender, disability, sexual orientation, you name it. Pretty much any other criteria that could amplify discrimination adversely or can impact inequities in health systems. So one of the ways that this phenomenon of bias from health AI systems could occur is when an AI algorithm, for example, produces results that are somewhat prejudiced due to some erroneous assumptions in the machine learning process or some other factors. Maybe the data is not representative. So many reasons why AI systems in healthcare can be biased, and we're going to explore that today. So in this session, I plan to speak about bias in health AI systems. I hope to discuss how algorithms can become biased. Like, how do these AI systems in healthcare become biased? We're going to find out today. How they get to enter the systems, the harmful effect that they might have for healthcare. And then, being a human rights lawyer, I'm going to use a critical human rights approach to explore the legal regulatory responses to bias in AI for health purposes. So finally, thanks to AI for PEP, this work has been quite great in the critical conversations today in addressing complex ethical issues when it comes to health AI systems. So to kickstart our conversation, I am sharing this statement by Stephen J. Gould, and it says, something has happened, something very big indeed, yet something that we have still not integrated fully and comfortably into the broader fabric of our lives, including the dimensions of humanistic, aesthetic, ethical, and theological that science cannot resolve, but that science has also, and without contradiction, intimately contacted in every corner of its discourse and being. So we're witnessing some form of something new, something big has happened, right? And I think I'll start my conversation on bias by sharing an experience I had with a health AI system. So before I share this experience, I'd like to say, at the very premise, every human being can be biased. Every system, every AI system or non-AI system, any technological system that serves human beings can be biased. I don't think, from my experience, I've seen a 100% bias-free AI system, and we can talk about that, if that's real or if that's something we can achieve, because based on your background, based on your experience, based on your identity, your nationality, even your profession, we all have our biases. For example, I'm a lawyer, so maybe I have more biases than most of you scientists, but one of the biases that we as lawyers have is that we're typically concerned with cause and effect. We're always very about, like, Who did this? Why did they do it? Who should we blame? Who should get punished? Who should be set free? Who should be rewarded damages? Who gets to win? Who gets to lose? In fact, in some of my teachings, I say, if there was a car accident and a lawyer shows up, our question as lawyers would be, who's at fault? Who's at fault? Is it this driver or that driver? Because we're built and trained with that bias. But maybe someone like Professor Jude Kong or Dr. Blessing, who are scientists, or maybe a medical doctor would show up there and be like, are you okay? Are you hurt? Can you move? Are you well? Compared to me as a lawyer, my bias would be focused on who's at fault. So in 2018, the picture you can see right here was the foremost conference on technology and AI, which is called the Annual Meeting of New Champions. This was my second time in China. It was in Tianjin. And I was literally standing in front of a technology that did not have a camera. If you can see, it's quite a small picture, but I'm holding a little microphone in my hand. And this AI system is developed by a collaborative group. And you get to speak into this AI system for 1 minute. And after 1 minute, it will tell you your weight, your height, your age, if you have cardiovascular problems, if you've suffered from lung cancer, if you're a smoker or not. It would even go as far as telling you your gender, your sexual orientation. If you have neurological problems, it would tell you, it would describe your skeletal structure, like you can see in the fourth picture at the bottom right. So how does this AI system work? It has no camera. It's not a Holy Spirit. It's not a ghost. But this AI system looks at a wide range of data. It looks, when you speak for 1 minute, it's dissecting your aphoncity, your breathiness of your voice, the coveredness of your voice, the creakiness of your voice, the diplophonacity of your voice, the flutter, the nasality, how much air is coming from your nose, how much of the pulse you have, your jitter, the roughness. It's looking at your tremor. It's looking at over 200 data sets, as you can see in the upper right, and it's dissecting all of this to be able to interpret if you have a cardiovascular problem. So of course, I'm really excited, like, oh, let's check this out. I really want to know how this AI system would work. Of course, it's not perfect, as they say in the small print, but it did get my weight correctly. It has no camera, but it got my weight correctly. It got my height correctly. It got my age correctly. It said I had no cardiovascular problems. I was like, thank God, though. It said I had no lung cancer. It could even tell if I had smoked that day or not. I don't smoke anyways. It got literally a lot of things right, but it got one thing wrong. And the thing it got wrong was something that is so apparent. And I'm sure your guess is as good as mine. It did not read me as a Black person. It read me as, what do they call it? A Mongoloid instead of a Negroid. And so I was the only one who was read wrongly in terms of my race. And so on one hand, I was excited that, oh, I have no muscular or psychological or neurological problem as per this AI system. But on the other hand, I was like, should I trust it when it did not even recognize me as Black? This was far back a long time ago. And I'm sure definitely maybe the AI system has been updated, but it speaks a lot about the bias in health AI systems. And one of the examples I'm just using to demonstrate our conversation for today. So in terms of the outline for our conversation, we're going to speak about the ontological consideration of AI, and then we'll move to bias in health AI systems. The third part would be human rights and health AI, which is a lot of work done around AI for PEP. And of course, we'll go into the fourth part where we think about solving the problem of bias in health AI systems from a human rights lens. So we can start with the first part. And to look at the ontological considerations of AI, I think it's important to recognize why defining AI is a difficult endeavor. It's difficult because the term artificial intelligence is seen as quite misleading. In practice, there is more of the A than the I. Because it's defined as a process that is applied to narrow inference tasks, where you think about like the use of large volumes of data and, a strong processing power must be available to find some form of association. So I know ChatGPT may make you disagree, but in law, we still struggle with the I, the intelligence part. We feel it's a bit misleading because we have not been able to decide as lawyers if there is a replacement for human intelligence or ingenuity. So we might be wrong, but that's where we stand as lawyers. Again, I'm just going to be giving you a lot of legal perspectives as per my profession. Secondly, AI is a loaded construct, right? It relates to more than 23 disciplines, And it's both a recent technology, but it's also not a recent technology, right? It's an abstraction that has existed for hundreds of years, but it's also a buzzword for today, right? The third reason why AI is difficult to define is because, you know, what is artificial is definitely settled. We know what artificial is. This bottle of water is, I mean, the bottle is artificial, but we don't know what intelligent is. So at the UN currently, and even the WHO, there's been a lot of conversation about, can intelligence be artificial? Can a non-biological being be intelligent? You know, even in law, not every plant or animal is considered intelligent. Talk more of a computer or math program. So in Africa, for example, some cultures do not consider goats to be intelligent, not to talk more of an AI algorithm that would determine your health status. The fourth point about the goalpost that keeps shifting. Calculators at one point were considered AI system in the scientific community, but now the bar keeps getting higher, right? The ChatGPT, you know, all kinds of series, volume 1, volume 2, iteration 6, iteration 7. What is AI keeps, you know, moving. But the most important point is we must rely on contextualization, which is very critical for health AI systems. Many scholars in health AI posit that if machine learning is not used, it should not be given the status of an AI health system. So when you talk about the use of AI for diagnostics, for treatment, for the speed of healthcare delivery, people have said the bar must be, it must be a machine learning algorithm that must be used, right? And so there's a lot of conversation around what is AI and what is not AI when it comes to healthcare. But if we go back to the history of the definition of AI, and I'm making this foundational point clear because when you're talking about bias in health AI systems, people realize that the biases already exist even before AI showed up. And so AI coming on board does not create new biases. AI systems may exacerbate or may diminish existing or extant biases that exist within the healthcare superstructure. So I'm not going to bore you with, you know, definitions around AI from like the Turing test, where you know, John McCarthy in 1956 spoke about, you know, AI systems have to be simplified to a computer program that can think humanly, think rationally, act humanly, or act rationally. But it's important to recognize that one of the areas where AI was first applied, the first early use of AI was pretty much in medical diagnosis. Most of you will remember your history class where they tell you about your history in AI class, where they tell you about the workshop that held in one campus in Dartmouth College in like 1956, where some scientists gathered together to think about if they could, in fact, the question they were asking about at the time was if they could create an artificial brain. And so it's important to see how the earliest work in medical AI was pretty much in medical sciences, where they were thinking about the applicability of AI methods to life sciences, especially the dendral experiments. Most of you will be very familiar with that, where, you know, scientists, geneticists, chemists came together to think about some biomedical application in the 1970s. But when we talk about law, we as lawyers, of course, I know you say we have plenty of problems, but we do not have one widely accepted definition of AI in law. So in healthcare, it's difficult for us to say that is an AI system and that is not an AI system, because we've queried AI within legal literature. However, what we've agreed in international law is that the fulcrum, the locus for describing AI starts with its algorithm. And so we look at this quote here by the UN High Commissioner that says, any technology that assists or replaces the judgment of human decision makers, whether it be statistics, linguistics, computer science, or any technique that uses a rule-based system that does some form of regression or predictive analytics or machine learning, deep learning, or neural networks, would consist of an AI system. And so there are so many cases in law where to decide if an AI system is used in healthcare, they go straight to the algorithm. What procedure is solving this problem? What rules are being followed? What is the design process? What method or system or program is making a decision? So the algorithm is the focus in describing where AI systems fall. I'm guessing most people are very familiar with the hierarchies of AI systems, from AI to ML to DL, but there are tons of examples. In fact, I argue that the highest use of AI per field, if you look at AI in fintech, in healthcare, in education, in labor and productivity and security, healthcare takes the highest of them. We've seen examples from, clinical automation for pediatrics, to nursing assistants, to even things like acne treatments, the AI systems that are able to predict that. I have the app on my phone. Well, let's not criticize the app. It's good. You take a picture, it tells you the kind of dermatological intervention that you need. So in part one, what I've tried to do is to give you a little bit of a foundation around AI systems, the definitional background for AI, its application in healthcare, and some of the constructions and some of the pushbacks in terms of definition, be it from healthcare to law and even computer science. But right now, let's talk about bias. What is algorithmic bias? Where do they come from? How do they get into health AI systems? And what are the reasons and results for bias in health AI systems? So when we talk about algorithmic bias, it pretty much occurs where an algorithm produces results that are systematically prejudiced due to erroneous assumptions in the machine learning process. Of course, there are very many definitions of what bias is, but it's important to recognize that when we're talking about bias, it's not just about the system itself. It's also about the application. It could also be about the data. It could also be about so many aspects of it, even before the AI shows up, and we'll talk about it very soon. But Panch et al. In their paper in 2019 talks about algorithmic bias, referring to instances where the application of an algorithm compounds existing inequities, meaning that there must already be an extant discrimination, like maybe Blacks are disenfranchised, or queer people are not given same access as as their counterparts, or people with disabilities are not able to access the same medical services. The AI system is considered biased if it compounds that existing inequity or inequality. The picture here is a documentary called Coded Bias. It's pretty much old, but it's on Netflix, that gives you an idea of how AI systems been developed. And I think that was actually an exploration by an MIT lab researcher. Her name is Joy Bulwamini, where she talked about the discovery of racial bias in facial recognition algorithms. And I'm sure you know today there's been a lot of debates, even amongst lawyers, as to whether facial recognition should be used in medical practice. And I think more countries are leaning towards the no than the yes of using facial recognition for healthcare. Of course, we've seen instances where facial recognition has helped a medical prognosis, but we've seen where it's been like causing a problem. So that coded bias gives you a real good insight as to how race could pose a problem when it comes to using system. And in that documentary, she shows a massive discovery of how when the AI did not recognize her having a black face, but it recognized her when she put on a white mask. It's actually a very good foundational piece to watch. But let me entreat you in discussing some of the ways by which biases come into AI systems. And it's important to recognize that psychologists claim that there are about 180 cognitive biases, some of which may find their way into hypotheses, or some of which are influenced by how AI algorithms are designed and function. So biases exist in the world over, right? There's bias everywhere. When people look at me as a Black person, there's an idea that they have in their mind, maybe positive or negative. When people see me limping, or they see me wearing a particular type of shirt, or if I'm putting on makeup, or if I'm big or short or hairy or loud, people just have biases that the world, of course, these biases are not right. That's why they're called biases, but they exist in the world anyways. And so we often think of biases resulting from preferences or exclusions in training data, but biases exist in the world as we speak, which is why Vivian Ming's quote is very clear. A lot of times, the failings are not in the AI system. It's not like, oh, this AI system has failed. Sometimes when we evaluate the use of AI systems in health systems, like when we look at the bias, it's not that the people who trained it are bad or that the people are stupid, they did not know what they were doing. It's a human failing. Is that we're not willing to address the fact that a lot of it has to do with lack of diversity in teams building the systems, or maybe somewhat innocently, they were not thoughtful about balancing the training set to give this thing to work efficiently. In China, when I was read as a Mongoloid instead of a Negroid, it wasn't that the system wasn't great. It was great. It could tell my height, my weight. It could tell my sexual orientation, my gender, brilliant. But because the data set it was trained on probably didn't have many blacks, so of course the system did not think in that way. So from my diagram on the, on the slide is bias comes from the world and they get into the data, right? In that data, you have biases like historical bias, you have representation bias, you have measurement bias. By measurement bias, this is where there is a systematic distortion in the results of treatment comparisons that occur when people are measuring outcomes. For example, when you see like researchers who are collecting data and all, they need to be aware of the treatment allocations that they are measuring each of the outcomes. So you see, when it gets into the data, there are different layers of the kind of bias that can get there. It could be historical, which obviously from like racism or colonialism or imperialism, you might have a dysfunctional approach to that data. There's also representation. How many women are here? How many men are here? How many non-binary people's data did you get? There's also a measurement bias. There's also a temporal bias, which could be when you assume a wrong sequence of events to someone's illness, which misleads our reasoning about the cause, like what caused this person's illness. It's like when people think, oh, this person is diabetic, then they must have been overweight or they must have eaten too much, without realizing that diabetes could come, the cause of diabetes could be like different. So that temporal bias occurs with a wrong sequence of events over someone's illness, and that happens a lot. Bias in the data could also be omitted variable bias. And I think this occurs where a health system or like where a health statistical model would leave out one or more relevant variables. For example, I don't know how to use it in a health context, but for example, the age of a car, right? The age of a car is negatively correlated with the price of the car and is positively correlated with the car's mileage. So in a healthcare system, for example, the age of a person can be negatively correlated to their ability to be a donor. So if a person is older, they are less likely to score on an algorithm's threshold for being a good blood donor or a good sperm donor or a good bone marrow donor, but they could be negatively correlated by an AI system with their strength of having strong immune response. I'll just give you an example to show you how, an omitted variable could actually even be a bias on its own. So going back to the diagram, bias can come from the world and it goes into the data. We've seen the various ways, and then it goes into the AI or machine learning system. And there you have algorithmic bias. There you have evaluation bias. So algorithmic bias is pretty much clear, where there's systematic and repeatable errors that just keeps creating unfair outcomes, whereby it privileges one arbitrary group over the other. Sometimes people have said, if you Google good nurse, you see lots of white women. Why are they not men? Are men not good nurses? People have said, well, men are not good nurses. I don't know. I'm just saying like that could be a bias in itself. And where are they white? Aren't they like Black or Hispanic or Latina nurses as well? I think this is different when you Google, when you try to search for images and you Google good housemaids, and then you see mostly women and they're mostly Hispanic, Latina. Are you saying white women can be good? I'm just saying the systemic, the way that the system repeats the errors can create unfair outcomes. And again, I'm just using very typical, very kindergarten examples, but I'm sure for health systems, they're a bit much higher. Another one is evaluation bias, whereby there is an unfair evaluation of a person's disease, be it for work or for competence, right? And even in that same machine learning process, you could have where there's an expected difference between, say, the effect of a reaction of a drug to a group of people to the effect that an individual might uniquely experience of the same drug. So that would be, if I assume that everyone who gets COVID would have problem with breathing, for some other person where they react by having like something on their skin, but nothing affecting their breathing, there might be an aggregation bias if I've encoded my AI system to just look out for breathing problems equals COVID without necessarily thinking that it might affect people differently. There's also the issue around the AI or machine learning algorithm coming up with what they call an aggregation bias, whereby because a group of people reacted this way, then it assumes everybody would react that way. It's also similar to what we call a popularity bias, whereby popular items are overly exposed in recommendations at the expense of less popular items that healthcare users might find maybe interesting or critical. For example, when ACADIC did some good evaluation around the use of monkeypox, the iteration at the time was focused around, monkeypox is something that affects maybe LGBTQIA+ individuals. And so therefore, when there were incidences of monkeypox in none of these minority communities, there is that popularity bias that if it's monkeypox, it must be gay men, or if it's this issue, it must be that people. You know what I mean? So that popularity bias could also be a problem. We could talk about linkage bias and the rest of that, but I think you have the idea as to how biases move from the world into the data, from the data to the AI and machine learning process itself that has its very different dynamics as to how the biases can occur in different ways. And then even after that AI and machine learning system is developed, it's been trained, it's been launched, it's come out, boom, you're going to use it for triage, you're going to use it in a hospital. There is the problem of human review. That's another level of bias as well, one of which is behavioral bias, where as a user, maybe a doctor or a nurse, I might have some irrational belief or something that unconsciously influences my decision-making process, right? So, okay, I see someone raising their hand. Please go ahead.
I think you finish your presentation. I forgot to mention, when you finish, then we'll take the questions one after the other.
Okay. There might also be presentation bias, right? Which I think ACADIC is very concerned about in the way it presents data, because ACADIC looks at a wide range of African countries. And also you don't want to say, by presenting your data, you don't want to make it look like this issue comes from this country. Like we've seen in the time of Ebola, where people just thought Ebola was a Liberian matter or a Ugandan issue without recognizing it as a global public health affair. So I'm just saying, even when the AI systems have even if there's no bias in the world, which is not the case, even if there's no bias in the data, which is not the case, even if there's no bias in the machine learning process, even the human review itself, the content, the production, the social way that the system is engaging with the public could also be biased. Sorry, I took a while to explain some of these because I thought it would be good to make people understand the various dynamics within which biases can occur and how they can get into AI systems. So in summary, we find that the bias can get into AI systems from the data. They can also get in from the people. And by the people, I'm talking about the people who fund, which is important. We've seen how money has gone into certain areas in public health and not certain areas in public health, right? The people who design, who develop, or even regulate AI systems. There's a lot of bias as well. When regulators are asking scientists to prove X, Y, Z without focusing on ABC, right? So there's a lot of biases too that can occur from people who fund, who design, who develop, who regulate, or even train or decode or code these data sets, right? And then, of course, there can be bias from the technology, which may come from cognition or from the way the technology is introduced or deployed. There's a short 4-minute video here. It's a very old example, but I think it makes the point clear.
A recent study published in Science magazine found significant racial bias in an algorithm used by hospitals across the nation to determine who needs follow-up care and who does not. Megan Thompson recently spoke with Stats Shraddha Chakradhar, who explained what the researchers found.
Where exactly was this bias coming from? There are two ways that we can identify how sick a person is. One is how many dollars are spent on that person. The assumption being the more healthcare they come in for, the more treatment that they get, the more dollars they spend, and presumably the sicker they are if they're getting all that treatment. And the other way is that, we can measure actual biophysical things, from lab tests, what kind of conditions or diseases they might have. So it seems like this algorithm was relying on the cost prediction definition. In other words, the more dollars a patient was projected to spend on the part of an insurance company or a hospital, then that was a sign of how sick they were going to be. And that seems to be where the bias emerged.
I understand that the researchers then sort of reuse the algorithm using a different type of data. Can you just tell us a little bit more about that? What did they use?
Yeah, so instead of relying on just costs to predict which patients are going to need follow-up care, they actually used biometric data, biophysical data, physiological data, and they saw a dramatic difference. In the previous model, the algorithm missed some 48,000 extra chronic conditions that African-American patients had. But when they rejiggered the algorithm to look more at actual biological data, they brought that down to about 7,700. So it was about an 84% reduction in bias.
Do we know anything about how the use of this biased algorithm actually affected patient care?
We don't actually know that, but as I mentioned, the algorithm is used by hospitals to help them flag patients who might need extra care in the coming year, whether it's an at-home nurse or making sure that they come in for regularly scheduled doctor's appointments. So we can only presume that if sicker Black patients weren't being flagged accurately, that they also missed out on this follow-up care.
Are there any consequences for the company Optum that was behind this algorithm?
Yeah, so the day after the study came out, actually, New York regulators, the Department of Financial Services and the Department of Health sent a letter to the company saying they were investigating this algorithm and that the company had to show that the way the algorithm worked wasn't in violation of anti-discrimination laws in New York. So that investigation is pending. One encouraging thing is that when the researchers did the study, they actually reached back to Optum and let them know about the discrepancy in the data. And the company was glad to be told about it. And I'm told that they're working on a fix. The other encouraging thing is that the researchers have actually now launched an initiative to help other companies who may be behind similar algorithms to help them fix any biases in their programs. So they've launched a program based out of the University of Chicago's Booth School to do this work on a pro bono basis so that they can sort of catch these things in other algorithms that might be used across the country.
All right, Shraddha Chakradhar of STAT.
Okay. So that's United. I'm sure you probably have heard the story. United Health Group's Optum division. The organization was unaware, and they were innocently unaware of the biases in the data used to develop a product marketed and sold to hospital systems to help identify vulnerable groups who would need like extra care or special care management. And it's interesting, and she mentioned it there, the algorithm used past spending data to predict the severity of illness without considering the broader societal factors. So if you're saying, people who spend more on health must need more health, without realizing that there are people who can't spend more in health because they don't have the money to spend. And so therefore, they got a point where they saw racial inequalities or inequities from the system. So they used a cost prediction analysis it's good they went back without looking at the biophysical data or the physiological data. And I think in health AI research, we talk about something called triangulation. You have to triangulate your data in a way that you do not miss. How many did they miss? They missed up to 48,000 chronic conditions that African American patients have. So this AI system meant to predict or to map or flag who is vulnerable missed out on who is vulnerable. So it's important to recognize this very big issue. But I think for me, what was promising here was the fact that, they agreed that, look, this is a problem. They went and they rejiggered the algorithm and got an 84% reduction in bias. This is the example of the omitted variable bias I'm telling you about, right? And, they were able to maybe rescue over 48,000 additional chronic diseases, right? So from a legal perspective, it's important to see that even when the submission was made, they did not violate any anti-discrimination law in New York. Like they did not, the law, they're fine, So the fact that you're not going against any law, or there are no regulatory protocols to govern the use of an AI system in healthcare per time, does not, so a blue check from the law does not necessarily mean a blue check in terms of meeting the desired outcome for why the AI system is built. So, like, you know, the AI system wasn't intentionally racist. In fact, it excluded race just to ensure that they identify patients from a more neutral, objective point of view. So it came with a race-blind metric. And I think that also could have been a problem. But yeah, it's interesting to see and to make the point that the reasons why we see bias in health AI systems could come from a lack of clear standards of fairness, right? What do you consider fair? And I think it's a conversation we normally, Jude Kong and us, and even like Blessing could speak about what we mean by our slogan of like fairness, responsibility. What do they mean in the context of your own AI system or dashboard? When you lack contextual specificity, for example, if I was their lawyer, I would ask, why are you using a cost prediction definition or analysis? By asking how many dollars was spent. Therefore, like, why are you using that as the frame? And what would be the implication from that, right? And of course, we know about the black box nature of deep learning. But as a result, we've seen how we could bring about diagnostic errors, inequitable access to healthcare services, and of course, health discrimination and ostracism. But let's not forget, there have been new cases of people dying as a result of biases from this system. Now, in the next few slides, I'm going to literally run through them because I wanted to foreground, in terms of solution, why I am proposing a human rights and health AI like perspective. And I think I would just rush through them because I'm assuming, you know, we all know what human rights are. We all know how they're established. But if you have any questions in this regard, you know, please let me know. So human rights are basic standards that values of dignity, freedom, equity accord. They are what every human being should face and enjoy. In law, we recognize human rights not only in Canada, but across all African countries where ACADIC works. There is some framework. In fact, all of the countries where ACADIC does work, the constitution of all countries recognize human rights, and they somewhat give or kowtow to global standards like the UDHR of 1948, the International Covenant on Civil and Political Rights, the International Covenant on Economic, Social, and Cultural Rights. Now, I make this slide very critical because in talking about regulating AI systems, a lot of scientists think that we need a new law, we need a new framework. And each time I engage with both government or supranational organizations, I always say there already exist norms, values, standards, and principles. You just have to co-opt it or adopt it or adapt it to the situation in question within which you want to regulate. It's important to recognize that every health AI system be developed, be it for ophthalmology or pediatrics, you must recognize that it must be designed with a rights to health framework, which is both recognized by local and international law. If you do not recognize health as a human right, you have no business working in AI for healthcare. Leave it to some other person. If you still struggle with whether health is a service or a privilege, rather than looking at it from a health perspective, then you have no business working in this field because you would somewhat inhibit the fundamental recognition of health as a human right, right? And we can talk about that. So I always clarify that the right to health is not the same thing as the right to be healthy, right? The right to health is not a programmatic goal to be attained. It's not just a programmatic goal to be attained in the long term. And I know that various countries have different dynamics. In Canada, for example, we have domestic laws like the Canada Health Act, Assisted Human Reproduction Act. In fact, Canada is one of the leading countries that uses AI for healthcare, and we can't compare it to the programmatic positions for a lot of African countries where we work in. And we've seen through ACADIC's work how health rights are affected by AI systems, including with the way that ACADIC has been able to leverage on intervention with like malaria, or COVID or monkeypox, that the use of AI can augment health rights in terms of disease surveillance, outbreak response, health systems management, but it could also diminish health rights, which is why it's very critical to have this conversation, because it could expand the digital divide on access to health. It could increase biosurveillance, which has been a very big topic in the last 4 months, and it could also affect patients' rights to healthcare. So what are some examples from a human rights perspective, issues that have related to bias in health AI systems? Very simple. In 2019, there was an algorithm that gave a dystopian account on HIV because of the AI system relied on fear-driven information from the 80s. So it's important to always recognize that information that exists out there in the open on the internet is not always recognizing what is it that has changed in a particular sector. We've seen the first release of Apple Health kits that did not include menstrual cycle trackers because there were little or no women on the team. We've seen how wearables provide less accurate results in people of color because of the bias in regarding their skin tones. In 2020, which is not too far from today, there are algorithms for a multi-specialty nursing practice which selected only white females. And in 2022, there was a health app that prevented persons suspected of being queer from using the service. So these are far back examples, but not too far examples as well, that gives you a typical example as to how AI systems in healthcare can be biased. But more importantly, like we've seen with Optums, there are avenues for which these problems can be solved or resolved. So in going towards the last part of my presentation, we're going to talk about solving the problem of bias in health AI. And we're going to do this by looking at 4 or 5 key areas. One would be to look at the ethical governance of health AI from the WHO. The WHO produced a guidance document, which we can definitely look at for a lot of inspiration. At ACADIC, we obviously rely on that as the Torah or the Bible. Secondly, we can look at law and regulatory responses to bias in health AI. I will entreat you on some of the ways that some laws or regulatory frameworks across various countries have dealt with bias in health AI systems. Then we could look at some technical or some technological solutions. And then I will share my own 7 propositions, and you'll feel free to criticize them, to critique them, or to let me know if that is the right track or otherwise. So let's start with the WHO document. It's a 150-page document. It was developed in 2021. This WHO guidance on ethics and governance for AI for health is a product of over 18 months of deliberation among leading experts in ethics, law, digital technology, human rights, and experts from various ministries of health. So according to this report, which I would subscribe every organization should have, in fact, print it out, don't share the soft copy, print it, let people have it in their desk. Because it's very expansive. It talks about, drug development to research in the use of healthcare for AI. And it recognizes AI for health in a way that it must put ethics and human rights at the heart of not just the design of AI, but the development and the deployment of it. In summary, the entire guidance document looks at 6 key principles, which are right here on the screen: protecting human autonomy, protecting human well-being, talks about ensuring transparency, explainability, and intelligibility, which is very critical for health AI systems. And then talks about ensuring inclusiveness and equity, and of course, promoting AI that is responsive and sustainable. I could explain a few of these principles, but I don't think that would be good use of our time. One of it is the second one that talks about promoting human well-being and safety and public interest. Something really interesting there. They talk about AI technologies must not harm people. For healthcare, you must satisfy not only the regulatory requirements for safety, accuracy, efficacy, but you have what they call the duty to warn. So where you think an AI system might hallucinate, I hate using that word hallucinates. With ChatGPT, when they say ChatGPT hallucinated, I used to say, what is hallucination? It's spilled out wrong information. It's misinformed. What is, I almost spoke my language. What is hallucination? Well, let me go with the general lingo. If you think your system would hallucinate, I think it's important you have a duty to warn individuals, because human beings will rely on your AI system to be able to carry out life-changing decisions, right? So again, like I said, this is just a very tiny itty-bitty summary of the guidance document, but this is the very foundation everyone needs to start with when we want to talk about regulating bias for health AI systems. It's also important to recognize that when we're dealing with bias in health AI systems, we're not dealing with anything new. In as much as big tech likes to make it look like this is new, we need to come together to regulate, it's really not new, because there've been use of technology in health systems, and even without technology in health systems, bias still exists. So the law already has somewhere to work with, right? And the first is the possibility of damages as a remedy. So damages that already applies to healthcare would extend to bias for AI systems, right? So if you're not a lawyer, damages, it's not like you're breaking something. Damages refer to the sum of money that the law imposes for a breach of some duty or the violation of some right. So when I say, if you don't recognize healthcare as a right, you have no business working in AI for healthcare, because where you breach a duty, where an AI system violates the health rights of a person, the person can get compensatory damage, or they can get punitive damage as well. This does not need a new regulatory framework. They already exist in law. Secondly, there is what we call strict liability, also related to what we call product liability today. So when a person sues you for let's say you have a product, for example, right? You manufacture some AI system, maybe it's a product, maybe a robotic system that detects if a person has COVID or otherwise. In law, you will be held liable if you're able to prove that you have a duty of care as a doctor and you breach that duty, and because you breach that duty, you cause the person a harm, and because you cause the person that harm, they're entitled to damages, right? Now, it's very difficult for patients to prove this with robotics, right? With nanotechnology and biotechnology, it's very difficult. So there's been conversations about strict liability, meaning that even though there's lack of explainability as to how your AI system caused harm for this person, the law might say, because we don't know, it's too black box, you that provided this product, you have to bear liability for this. So it's seen as strict. We might not be able to prove how you caused a breach of duty of care, but we know that your AI system did all these things to this group of people. Therefore, the law might ascribe some form of strict liability. Again, this is not new. People always say, oh, maybe this is, people have criticized it by saying maybe this is too harsh on people who are developing health AI systems. I said, no, it's not. In law, for example, if you use certain explosives, what we don't need to figure out, how did the explosive blow? Is the explosive that caused my hand to follow? I don't, like, you use an explosive, you are strictly liable. If you own a tiger, even if I jump into your compound, you're not going to say, well, you jumped into my compound and my tiger beat you, or my tiger is friendly. Maybe it was the way you put your hand. That's why it now beat your hand. The law would accrue strict liability because you have a wild animal. A wild animal is not meant to be in the public domain. It's the same thing about anything that involves serious risk or serious harm. And I think in law, there are cases in the EU and in the US where courts have regarded some medical software as having some form of strict liability. Of course, it's still debatable. In some jurisdictions, if a dog bites me, the dog is automatically liable. In some jurisdictions, they might have to say, did you annoy the dog? Why are you calling it a different name? Maybe its name is Bingo. You called it Binga. It got angry and beat you. But in most jurisdictions, they will say, once a dog bites you, the person who owns the dog bears responsibility. And you may see some of these on Judge Judy. But the third point is about something new called no fault, no liability compensation fund. And I think it's one way by which health AI systems are regulated. Now, a no fault, no liability compensation fund is where you provide payment to individuals who suffer medical injuries due to the use of AI technologies specifically, especially if they're deployed nationally. For example, in New Zealand, patients can seek compensation for medical injuries through this no fault, no liability scheme if an injured person got that injury from a government-funded or government-licensed AI system. So the person gives up their rights to seek damages, but they will get some form of payment. So you're not blaming anybody. You just go to the government, you get your pay, you move out. The other ones are preemption laws. Pretty much if the health AI system is approved by a federal regulatory agency, there's the doctrine of preemption that would apply. So it's pretty much a decision taken by the central government to validate a medical technology, and that will supersede any cause of action guided by civil laws. There are tons of data protection laws and guidelines from the GDPR, but even before then, we've had the WHO's Astana Declaration on the use of digital technology. There's the new UNESCO principles on AI. All of this provides some form of data protection and the rest. But let's not forget that, again, most of the laws still exist with health law, with bioethics, and they provide some form of industry standard. For example, if your AI system is going to be embodied, by embodied in this field, we mean if it's going to have a shell, like it's going to be a robot that distributes sanitizer, for example, the regulatory protocol around it is different from if it's a system used for triage. Say, I walk into a clinic and I want to know if I will be seen first or last. One of them is just going to rely on principles that govern that particular industry. But the other one, having an embodied system, might be seen as not only a service provider, but also a product, because it's visible, you can see it there. And so the way it's designed, if it moves or stays, can it cater to persons who are mobility impaired? All these questions will come into play. So there is a lot of, in terms of regulatory response, it depends on the technology and what is being deployed within the system. But the last thing I would say is I've always talked about co-regulation. And in the case I shared with you with Optum, you find that if they had done some form of co-regulation, they would not have looked at a cost prediction analysis. They would have considered, some form of sociological or maybe other technological solutions as well. Now, I'm not a machine learning engineer, but I do know that there are some work being done around what we call counteraction. This is where there's some form of clinical decision support system or a multidisciplinary data science team to help counteract bias. So where there's a decision support tool, such as some multidisciplinary team, you have ethicists on board, you have lawyers, you have, data scientists, ML engineers, and the rest, maybe they're able to counteract bias by the way they support that decision-making process or tool. Another could be control mechanisms, and I'm sure most of you have heard this a lot, around human in the loop, ensuring that there is some human being somewhere that would approve or decline the use of an AI decision. I personally have a problem with human in the loop, but I'm not going to use this time to, I'll just quickly say human in the loop does not always solve the problem, because the human being in the loop set can be a dunce. They can also be biased, like I said earlier. So putting a human being in between an AI decision-making model might not necessarily solve the bias. It might even exacerbate it, right? So it's not about the human in the loop. It's what kind of human, and does the human make it right? We can talk about that. But when scientists just talk about human in the loop, they make it look as if humans are some neutral, objective, angelic intervention that could help, remove or delete the bias, from there. So we can, but it's also a good control mechanism. At least a human technologist can see where an AI system can be very hallucinating or very critically biased against a race or a gender. There's also the use of reverse engineering when it comes to affirmative data. So the use of preferential randomized data instead of observational data, right? And so I think both occur when you, like Blessing was just entreating me earlier today about what it means to scrape data from social media. And I asked him, what does that mean? And he says, right now on Twitter, before you could scrape as much as 10 million tweets a year, but now Elon Musk has made it a little bit different. And I think it's important to recognize that beyond what is existing in real life, it's important to think about sentiment analysis. What do people think about getting a COVID-19 vaccine? That could inform the uptake or downtake around, vaccine hesitancy and the rest of that. So you need to sometimes ensure your data is affirmative and you're looking at randomized data and not just observational data, but also you can use counterfactuals, right? In some of this regard to ensure that, you're able to test the data set itself and to ensure that you're getting both suggestive and even experiential data as well. Now, we will go to my my propositions, and I'll try to run them very, very fast. I as a human rights lawyer, I always use a human rights lens to tackle bias in health AI systems, because I know it's a very high threshold, but I think it's very critical to prevent the kinds of issues we're seeing in today. And the rationale for why I use a human rights lens is because I feel that human rights provide a common language to frame harm, and human rights law specifically offers a clear parameter to dealing with bias. I also feel that human rights provide specific principles that can address issues of like discrimination, issues of like marginalization, and even this big discourse around the digital divide. I think they're very important. So yes, common language, yes, specific human rights principles, but more importantly, the third one is about, I feel like human rights provide impact assessment for purposes of independent oversight and effective remedies. People have said, Jake, why do I not, like I've written papers where I've said ethics are not enough. I think we need to go beyond ethics. And people have said, but ethics is what we need. I was like, yes, but ethics do not take anybody to prison. Where AI systems can cause the death of people, somebody needs to be punished. And I'm not wicked. I'm just saying, I might be joking, but what I mean is there needs to be accountability in terms of oversight and remedies like damages, payments, orders, bannings, moratoriums, and the rest of that. And I think my first example, which is not from me, by the way, it's from the UN High Commissioner for Human Rights, talks about the need for a moratorium on AI systems that are high human risk. So in September 2021, the United Nations High Commissioner for Human Rights proposed that any AI application that cannot be operated in compliance with international human rights law should be banned, and moratoriums imposed on the sale, the deployment, the use of such AI systems in healthcare because they carry high risk. So when people share all these news stories about this AI pause, like, oh, big tech in the US are saying, can we just pause a minute? This AI thing is going too far. I laugh and I'm like saying, this is not the first time Africans have called for AI pauses for like the last 7 years. The UN has talked about AI pause for high-risk systems. So I think a moratorium on AI systems that are high risk is a great proposition. Second would be the right for people to contest bias. There must be provisions for people to contest where there's no reasonable explanation as to why a system was biased towards them. And I think the Office of the Privacy Commissioner of Canada actually made some recommendations for the reform of the Personal Information Protection and Electronic Documents Act of 2000. And I think they're proposing a right to meaningful explanation where bias from AI system has occurred. It's very similar to, I think, Article 15(1)(h) of the GDPR, but I think it's an important framework to introduce where people should be able to contest bias, or to say, if this bias happened, can I know why it happened that way? I'm not going to go over the third point, which is human in the loop, to address the obligations of accountability and explainability, but I think it's important. It's an important point. AI should effectively communicate and collaborate with people to augment their capabilities. So it's great to use AI systems, but they can be used in consortium with human experts as well, right? So obviously, no full transfer of decisions should be made from humans to medical machines without some form of human expert approving such, if the case may be. The fourth proposition I have is about debiasing orders. You see the way Optum had to go back to rejigger. I didn't even know that was a word, rejigger the algorithm, rejigger. Sounds like they're going to shake it up a bit, which is what it should be. I feel like companies should be asked to debias their systems. And I think debiasing techniques can provide some remedy for bias in health AI systems. I think Google had rolled out some AI debiasing initiatives where they were trying to include more responsible AI practices. So they advised for what they call algorithmic hygiene. And I think it's something that should be done to ensure that as much as possible, training data is representative. So when I was in China and it did not view me as Black, but describe me as Mongoloid instead of Negroid, I feel if they had gotten a debiasing order, if that was a AI system used in healthcare, that could help in terms of ensuring more representative data. The fifth would be a human rights algorithmic impact assessment. AI companies that work in healthcare need to, at the end of every year, before they do their Christmas or end of the year party, they need to do a human rights algo impact assessment to be able to check how their AI systems, or actually to help them study and adjust their algorithms in ways where it might have been inaccurate or unfair or discriminatory or biased. So it's pretty much like having an impact assessment. And I think by law, this is one of the things that I propose should be initiated. I think in the US, in 2019, 2 US senators proposed or sponsored what they call the Algorithmic Accountability Act. I don't know if they finally passed it into law, but even the AU AI Act, the EU AI Act is thinking of that as well. The sixth proposition is the patient's right to be forgotten from AI health systems. And I think this is very critical, especially in the data space. Patients should have their right to remove any information about them from AI systems, because sometimes these systems are permanent, whereby systems would use historical data to categorize people as being maybe good candidates for insurance or not. And I think we can talk about the right to be forgotten. The right to be forgotten is pretty much a legal intervention that started in 2006, I think in Argentina, where there was a proposition to ensure that people had their information removed from every internet search. And I think the same can be applied for health AI systems, just to ensure some form of accountability and fairness, right? And the third is what we call a third world approach to harmonization of AI standards for healthcare. So it's pretty much a decolonized global harmonization of regulatory standards that is pro-poor. And I think one of the good things about AI for PEP is that we're focused on the global south. And I think it's important because there's not much, there's very little, very paltry focus on what regulatory standards should be when it comes to bias in health AI systems. So we need to be more critical in terms of being decentralized, in terms of being more open-ended, more consultative, more communitarian when it comes to the harmonization of regulatory standards when it comes to bias. So when we use AI systems, how many of them can be deployed in Swahili or in Pidgin English or in Igbo, or like, how do you ensure AI systems can recognize languages that are not the typical English, French, and the rest of that? Like, how do we build AI systems with that form of accountability, right? How do our sample cases look like Blacks and look like people who are not, like, look at people who are differently abled, I also have other recommendations, one of which is upskilling. Of course, every healthcare practice professional needs to ensure they know how AI systems work. They need to understand the fundamentals and basics. There's need for research and development in terms of programmatic intervention. There is need for non-techno-solutionist intervention. Sometimes I've said the best AI in some health settings is no AI. There are medical situations that require human touch and human engagement that a machine would never be able to provide, in my opinion. And so while we're talking about technologically solution-based intervention, we must think about the non-techno-solutionist interventions as well. We need more diversity in medical school. We need more AI for PEP programs. We need more inclusive design teams. We need more co-production and co-regulation. And I think the last point would be incentives. I think we need to encourage developers we need to dash them money. We need to incentivize them when they create systems that are not biased. For example, there is a pre-certification program of the US Food and Drug Administration, and they have this thing called the Digital Health Innovation Action Plan. I mean, it's a pre-software certification program, but it's streamlined in such a way that they are trying to help software manufacturers in the medical device field to explore and evaluate models that to incentivize them for developing systems that would avoid biases in this regard. So, in summary, I've tried to take you through bias by telling you about, the definition of AI, why it's difficult, what it means in healthcare, and then we talked about bias, what bias means, how they can move from the world to the data, and from the data to the AI or ML system, from the AI ML system to even human review, and even after human review, the AI like bias can still exist. Then we moved into why I'm using a human rights law or a more legal framing to tackle bias in health AI systems, not to say ethics are not good, but to say we need more than ethics, we need more law, and by law, we need a human rights approach. And I started by establishing health as a human right. I established some of the norms and principles from the UDHR to the International Covenant on Civil and Political Rights, to the International Covenant on Economic, Social, and Cultural Rights, and how these laws are very critical as the minimum core to begin the conversation. We talked about the WHO standard as the Bible or the Quran or the Torah to begin the conversation, and then we moved on to 7 regulatory propositions. Before that, we also expanded on some of the ways that the existing superstructure in law and regulation could apply to biased health AI systems, and I suggested some recommendations or ideas that I think could flow. So thank you very much for the audience and the intervention. I am grateful for, and sorry I couldn't take questions as we were flowing, but now I'm open to your questions, suggestions, critique, contribution, disagreement, violation, protest, whatever it is you think can contribute to this discourse. I'm also interested in hearing some of your ideas as well. So over to you, Dr. Blessing.
All right. Thank you very much, Jake, for that inciting talk. I mean, you actually took us all the way from understanding the foundation of AI system based on from the legal lens to the bias issues. And it's quite interesting that the issue of bias is not just a new thing, and the AI systems are not introducing biases, as so to say. They actually either amplifying it or demystifying it, as the case may be. So that's a very good one, and we thank you very much for talking to us. At this point, I would like to be taking the questions, and normally we read the questions and you give a feedback based on questions that people ask. You can also send your questions if you haven't sent, if you want to say something. Have people that want to say something. Okay, so Monzogun say Yedio want to say something. So if you're there, could you please put on your microphone and ask your question?
That's Muzungu.
Muzungu, okay.
Yes.
Muzungu, if you're there, could you?
Did I get it correctly?
Almost. Munzungu.
Munzungu, okay.
Munzungu.
3 vowels, 3 U's, you can't miss it. Congolese. So
yes, I figured.
Okay. Could you ask a question if you?
Yes, of course, absolutely. I'm not going to keep you too long. First and foremost, Jake, thank you so very much for the presentation. Absolutely amazing. Thank you for keeping about human rights, because that's important. So here's my question. So in accordance with the ethical governance structure in AI-powered healthcare, what legal and regulatory consideration must be prioritized to effectively address existing future disparities in AI-based decision-making tools? And I'm sharing the question in the Q&A just to make sure you can have a reference to it, but more to the story, ethical governance, the overall structure, what legal and regulatory things should we keep in mind when it comes to addressing disparities, both existing, but also the future disparities that come forth given the evolution of AI as a system? So thank you. Hope that makes sense, but yeah.
Absolutely, really brilliant question. I think it's even the most important question we should always ask, right? I think what must be prioritized to effectively address these disparities when it comes to AI decision-making tools. I think every AI system in healthcare must be designed and applied as an open system. Right. By open, I mean everyone should be able to go back to redo, rejigger, reevaluate, reprocess, redesign new data set. Like any AI system for healthcare that tells you we've done X, Y, Z, this is going to be the best system, is going to include everybody, it's a lie. or any AI system that says this system does not have any bias, it's a lie. Because based on our experience so far, we know that bias is not something that can be eliminated by technology. Bias it requires training. Just think about what it takes for somebody who's not from our culture or who's not African to understand that we are, like, some people in 2023 need to understand that blacks and whites are equal, and they don't have that understanding. So if that has not been solved in society, it can be solved by technology. So the solution is not and that's why it's important to talk about global health perspectives when it comes to regulating AI systems. In Africa, we believe in a communitarian perspective. By developing an AI system, we need to keep it open. Does this system work for the same pregnant woman who is in some part of Kinshasa, or like the trader who is selling in the market? Can they use this technology? Do they have access to this technology? Would they be, by any chance, come in contact with this technology? And what are some of the things that we've created that might take them away or ostracize them from using this technology? So, of course, your technology cannot serve everybody equally, but if you keep it open, if you keep it constantly being interrogated, if you're able to say, we're willing to debias, we're willing to get better, we're willing to be iterative, that's the most critical aspect of it. So it's not just warning people that this system might be hallucinating, this system might provide wrong use. What would you do when it provides wrong use, right? And these are the ways we hold ourselves accountable, by saying, if this system causes any form of wrong, error, damage, or whatever, here's a number to call. These are the ways we want to engage. Like any AI system developed today is not perfect. It must be open. It must be communitarian. It must be reflexive. It must be co-produced. And I think that's the most critical aspect of it. It must be open to be interrogated, and it must not be closed or finalized. That's my answer to the question.
One final thing to mention, sorry, just one quick thing, just 2 seconds real quick. Just a quick final note that I want to just highlight, and just again, thank you so much. Cybersecurity, and I only mention it because from an AI perspective, that element when it comes to the impact of cybersecurity, when it comes to healthcare-related services, just a little mention, but I'm done. Thank you, that's it, I'm done.
Thanks so much, Muzungu. In fact, cybersecurity is one of the 3 core aspects for engagement and let's talk about it when it comes to health AI systems. When developing health AI systems, as a lawyer, people always say that we ask for too much. But I say, no, we ask for the required. There's no health AI system that should be developed or deployed if it does not explain how it protects its users' data. How are you protecting my data as a user? Where are you using my data? And at what point would you delete my data? These are information you think are very commonplace, but not many systems do it, right? You log on, put in your name, age, date of birth, race, citizenship, this. How many children do you have? Last medical history, last test of this. Okay, I give you all of these things. Where are you storing them? How are you securing them? If there is a breach of data, would I get an email? Would I get a text? Tons of big tech companies are going through problems right now. Facebook is still trying to compensate how many 100,000 of people because there was a data leak in the US between one time to the other. So to prevent all of these things, you can just have a one-pager FAQ by the website. This is how we use data. This is how we try to protect data. These are some of the issues we can't even solve. Just so that there's what we call explainability. There is transparency, that you're being open enough to engage on some of the faults with the use of AI, so that people can say, based on what I've read, I don't think I'm comfortable using this AI system. And the last point I will make is, because of cybersecurity concerns, human beings should be able to say, where is the alternative? If I walk into a hospital in Toronto or anywhere, and I have to is an AI system that would register me, you should have an alternative if I do not want to use an AI system, right? So these are conversations that we need to have even in this regard. Thank you so much, Muzungu.
All right. Thank you very much for the feedback, and thank you, Muzungu, for the question that you asked. So over to Moronji Judith for your question. Moronji, if you're there, could you please turn on your microphone and ask your question?
Thank you so much. I just have 2 questions. One is, how do we bridge the gap between AI developers, users, and legislators? because while we are advocating for better laws, there's the instance whereby there's no convergence between the developers, the users, and the legislators. So the laws may not really cover what they're supposed to cover. And then the other issue is, how are we going to address the concern of informed consent in African countries where specifically some do not even have data protection laws? And now the advancement of telehealth care is here with us. AI is here, and there are no clear-cut provisions on how to go about issues of informed consent. What can we do? Thank you.
Great question, Murungi. To answer your first question, how do we bridge the gap between AI developers, users, and legislation? Very important question, because these different groups seem to work in silos. And I think that has not been helping the case, which is why in my presentation, I push for something called co-production. To produce laws that would govern AI, we need developers in the room. We need scientists in the room. We need ethicists in the room, not just lawyers, because they always push regulation to lawyers. Oh yeah, lawyers, tell us, what is the law? What is the rule? And we've seen that with other technologies, law has always fallen behind because lawyers didn't go to medical school. Lawyers don't work in AI design teams. Lawyers don't use AI health solutions where practicable. So we might miss out certain things, or we might even be inimical to technological advancement. We might be so hard pushing that we stifle innovation. So when we're talking about regulation, it needs to be co-productive. And I think that's one of the things I make mention of. The only way to bridge developers, users, legislators is to ensure that these individuals, just like the WHO did with their guidance document, you need people who work at the Ministry of Health, you need people who are volunteers, you need people who work as nurses, you need people who work as taxi drivers, who are going, not even ambulance riders, who are going to pick people up. They need to be part of that system, right? To ensure that you have a more inclusive and holistic, co-productive regulatory system. I know it's difficult. I know it's hard, but this is where we are in 2023. Technology is no longer siloed as per one profession or, one sector. It has to be engaged, all of these subgroups. And I think the issue with informed consent, so it's not just informed consent. In law, when it comes to data, we say you must have free, prior, and informed consent. So free, meaning that you did not force them to produce that information. You do not say, if you're not going to use our app, you will not get treatment. If you're not going to use our app, you will not be able to give birth in this hospital. That is not free, because the women, we've seen it happen in Africa. Tech developers go and they want to get data by all means. Oh, we've brought it. If you don't use our app, we cannot give you free mosquito net. If you don't use our app, that's not free. You're forcing them to use the system. It has to be prior. By prior, we mean you get their consent before you take their data, not after. You not say, by the way, we're using your data to do some training. Then it must be informed. This is where your data is going. This is what we're going to use your data for. So we know, and you're very correct, not many countries have data protection laws, not many countries have data protection principles, but the standard, the regulatory standard is not the country you're working in. The regulatory standard is far above the country you're working in, which is why you must look at the WHO guidance. The video I shared with you is a very typical example. When their algorithm had a problem, they reported to the New York office, and the New York office said, you did not violate any anti-discrimination law. There's no law you've done here that is wrong. But we saw that what they did affected the lives of Black African Americans in the US. So the standard is not the law of the land, because laws are very hard to catch up with. Many countries don't even know how AI systems operate. Data systems in many third world countries are not robust and holistic enough. So the standard is the WHO guidance. The standard is international principles. Right? Yes, you might not be punished if you don't fulfill the data laws, but to ensure that you're meeting the demands of an ethical, responsible AI provider in healthcare, international legal frameworks are where you should look at.
Okay. Thank you very much for the feedback. Thank you, Judith, for your question. Right now, we'll go to the chat and see how many questions we could go through today. Theophilus is asking, what can Africa do to position itself as one of the greatest AI hub in the world?
Very important question. Yeah, I don't know if we can, well, we can be one-off, but we cannot, I don't think we have already, I don't know if we can become the greatest AI hub in the world. We can be one-off, but when it comes to health AI, I want us to rephrase the target. The target should not be greatest AI hub. I think we can be the greatest use of AI for certain sectors, right? So I don't think we should care much about our advancement or use of the technology, but we should be particular about how we use the technology in certain sectors. So when I speak to a lot of African governments and we sit across the table to talk about the use of AI and what sectors to prioritize, I always tell them, AI is just a tool. How would you use this tool best for your existing country? If I give you a hammer, you don't have to create a table. You can use it to repair the roof that is leaking, and I think the same thing applies to AI. So Nigeria would say Nigeria wants to prioritize the use of AI for healthcare, for labor and productivity. Kenya wants to prioritize the use of AI for fintech and to increase like jobs in the digital economy. Mali wants to look at the use of AI to prevent conflict, right? Some African countries are saying, tell us how we can use AI to reduce malaria levels, to reduce maternal mortality. They don't care about self-driving cars, right? They don't care about like going to satellite and flying to space and dropping their flag. I'm not saying it's not great, but I'm saying the best way for Africa to position itself as the greatest AI hub is to deploy AI with some cultural relativist approach by saying this AI is too big, it's too broad, but we want to use it for healthcare. And I think with ACADIC, we've seen how, is it the Guangzhou, I don't know if I'm pronouncing it properly, the Guangzhou province in South Africa is able to deploy the use of AI in terms of informing their COVID-19 policies. That's the kind of iteration we want to see, not just for this technology to be used everywhere and, we now technologize, but for the technology to be used to solve specific African problems.
Yeah.
That's my opinion.
Oh, yeah. Thank you very much. Just in addition to that, we are also preaching the issue of decolonizing research, where we try to use locally relevant data to train our models and our AI models. Like in Africa, I cannot come and train my model with some sort of data set, a medical data set that was gathered in Harvard or Chicago somewhere, and I want to deploy it in Africa. So that is also very much one point or one way to go, to be able to train our models and our AI models based on the locally relevant data that we get. So thank you very much for the feedback. I'll take another question from Richard. Richard is asking that how do we make sure that as we deal with AI bias in health, we also do not impede on time taking for solutions on the market, not to avoid what happens in new drugs, since AI systems are trying to help and fill that gap. Over to you.
Great question, Richard. And I think this is a very important question, a good point to say. AI, there's a competition with science, with the AI science field. And maybe Dr. Blessing can agree with me here. Everybody wants to make the latest, the fastest, the best test without recognizing, and I think it's perpetuating this idea that if you are slow, you miss out. Let's do sharp. Let's release that, first, and there needs to be a call for people to take, science takes time, research takes time. It's painstaking, right? Especially when you're trying to deal with the issue of bias. Do you know what it is to have a representative data set? It's very difficult. Data set that has all populations recognized and it's a good quantum quantity, and it's very, very hard. It's good to just copy one from Harvard, copy one from Yale, or copy one, but it's difficult to ensure that it's representative, it is interoperable, and that it applies to the country within which the system will be used. So yes, I think we can try to be hasty, but I think time taking, and I think somehow we must decolonize this idea that the first person or the fastest would be, and I think it comes from the capitalist or the business-oriented side of AI health systems, right? For example, in the example I showed you, I'm sure they used a cost prediction analysis because money was in the front and center of the deployment of this technology instead of a more communitarian or solutionist perspective. So whilst there is some gain in being fast, I think we need to sort of encourage people to take their time and give them a much longer process in their development. But more importantly, if you want to kill time, they say if you want to go fast, go alone. If you want to go far, go with people. We need to see more collaborations. As you're seeing UNITAR and CFAL, IDRC, like we need to see collaborations of 15, 25 groups working together. We need to see data banks, data scientists from third world countries collaborating with, like we need to see that level of robust collaboration. That's what's going to get us faster, especially when it comes to new drugs. And I think the reason why we always preach taking things slow is because AI for health is not AI for transport, whereby if the model causes a problem, we'll just park the technology one side. The impact could be life-changing for a lot of people, right? It could be really disastrous, especially when AI for health systems are deployed by an entire province, an entire hospital, an entire sector, an entire ministry. When it causes a problem, what we saw with Optum could be exacerbated times 10.
Interesting one. Thank you very much, Barrister Jake. Another question here is coming from Israel Manga. Israel Manga is asking, what do you think about racial identification on the discourse of neutrality? To me, do you think that the identification of race by healthcare AI systems is necessary in the first place?
It is. No, it's a very important question. Very important. People ask this question all the time because you don't want your system to be racially biased. You're like, let me remove race, right? Let me just get natural, whatever. Just get so the rule for me, there is no objectivity or neutrality in AI. It does not exist. Neutrality is not, because human beings are not neutral. Except you're trying to, even plants, animals are not neutral. They're all different. So any system that uses neutrality and objective, neutral, it will fail woefully. I think every health AI system should consider race, but it's how that matter the most. Where does it seem to use race and how does it use race? I'll give you an example. 1 in 3 Black person would suffer from prostate cancer in their lifetime. God forbid, though, but amongst all of us here, maybe one of us. I'm not saying any of us here, but I'm just saying prostate cancer has a much higher incidence in Black men. So if you're going to develop an AI system that looks or diagnoses prostate cancer, if you're not looking at race, what are we doing here? We're wasting our time. If you're going to deal with sickle cell anemia, which affects Black people 500 times more than it affects a white person, in Nigeria, for example, every day, 210 children are born with sickle cell. It's a Black man's problem. If you're going to create an intervention for sickle cell, you have to consider race. So it's not that, let me avoid the racial identification. You have to recognize that. So think about race, sexual orientation, gender, marital status, weight, height. All of these indices matter depending on the health AI system. But the other thing I would say is where you ask that question or where you bring in that information also matters. History has shown that when Black people engage in clinical systems and they ask them their race, it already makes them feel like this system is not going to work for me, because most times when they ask you your race is to disenfranchise you and not to include you. So maybe in a design process for AI systems, you might want to ask race at the end. Before you say, thank you much for using, could you please tell us where you're from, what's your age? Instead of saying, welcome to this thing, race. I've seen systems where, welcome to this service, bam, the first input, race. I'm just saying, hey, they're not asking if I'm Black. And if I'm in a white country, I'm saying, yeah, they're going to remove me from this team because I don't qualify, right? So the design process, the iteration process of where to ask for race is important. One of the big failures you would get when you're even seeking for funding is when you bring up an AI, they ask you how many Blacks were here, and you say you don't know. That's going to be a big red flag. Sometimes you can, what do you call it? You can anonymize certain information for certain reasons, but does not mean you don't recognize them. I hope that answers your question, Israel.
That's a good one. Thank you very much, Jake. I think you really made quite a good point there, because when we build AI models, we also consider all those demography to actually get a very informed prediction. I mean, you want to build an AI model that you can say, okay, certain class of people are behaving like this, and that can help you to make your final decision. Also help the policymakers in trying to understand the prediction that you're making. I think it's a very good one. Thank you very much. Rosaline is also asking a question here, and Rosaline is thanking you for the insightful information that you have put up to, for this talk. And she's thinking that can African lawyers ensure and press harder on the international community to come up with human rights algorithms that can eliminate bias, especially in protecting the African continent, and ensure that they help regulate the system consistently? I don't know what's your take on that.
Thanks, Rosaline, and thanks for dashing me the doctor title. I'm not a doctor yet, but I'm planning to become one soon. I'm still working on my PhD. But yes, I think this is the point Dr. Blessing was making about decolonizing research, right? First of all, how many African lawyers work at the international space? Like, first of all, when you're talking about designing AI systems from the WHO to the UN, UNESCO, UN, all these big organizations, how many Africans that are in Africa, that are from Africa, are engaging in this process, right? Very little, minimal, very, very minimal. So there's a capacity gap. And I think we need to recognize that the African continent is not dealing with an AI lacuna. We're dealing with a broader range of technological gap, operational systems, internet connectivity, hardware devices, computers, cloud platform. Like, we're dealing, if you don't understand the dynamics of what Africans are dealing with, then you can't build systems for them. Which is why when people talk about Africa needs to leapfrog, how do we leapfrog is a conversation people don't really recognize. Which is why I said sometimes no AI is the best AI. Some African states have said, we don't want to use AI in certain areas until we understand how it affects us uniquely, until we see in the conversation that you've included our countries in your evaluation, then we can engage. So I think the best way is, one way to encourage, I try my best to encourage more lawyers to engage in the AI space. You don't need to be a guru. You don't need to be, people want to leave their profession and jump into data engineering and machine learning, software engineering. I said, no, as an ethicist, as a sociologist, as a mass communicator, as a banking and finance expert, as a painter, right? You can engage, you can provide some value in this discourse. So lawyers do not need to even engage at the international level. They can engage at the local level to say, this is how we can use AI first of all, always ask yourself, what is the problem that can be solved? And then, can it be solved by technology? If it can be solved by technology, can it be solved by AI? And if it can be solved by AI, where has it solved it? And then we apply it here, right? The way AI has advanced when it comes to radiology has been exponentially brilliant in terms of, wow, AI can read diagnostic information, can read X-rays 500 times faster than a human being can read it. But I don't think AI can help with giving birth to children, because women still want that physical touch of a human being saying, you sorry, you can push, you can do it, compared to a machine telling you can push. Like, it doesn't have that same care and support. So we all use AI on our phones, on our email, and we can decide for our own communities and our own countries where to prioritize, be it from a legal perspective or from a non-legal perspective as well.
All right, that's a good one. Thank you very much. Adekunle is also asking a question. Adekunle Adeluoye. It says a very educative and insightful presentation, Dr. Jake Effoduh.
I accept it.
Yeah, what do you say? What do you say to the cases where developed algorithm leverages data collected during deployment or use case to further iterate and enhance their model without additional express permission from the users? to use their data for training or even an opportunity to get that. Meanwhile, as you mentioned in your presentation, there is a need to keep the solution open and iterative as a means of continued rejigging of the built model. And this consent be included in the privacy or terms used, term of use document at the onset. Our users are signing up to use the AI tech, I guess. So,
right. Yeah. Very good question, Adekunle. And I'll give you free legal advice here. As a developer, that is what I will advise. And if you read a lot of the terms and conditions, it's important to let people know this data will be collected and will be used for research purposes, analytics, that are like, from a developer's point of view, you want to ensure that your privacy terms and agreement is as inclusive as possible. So if you know you're going to use this data for another round of another intervention, you might want to put it down there and make it clear. This is exactly why big tech gets away with a lot of things. Remember when Instagram started, Instagram even said they have a right to share your picture and use for advert, with or without your consent, whether you agree or not. You'd already, speaking pidgin, so you've already clicked and accepted it, so therefore they can go ahead with that process. So I'm saying in your privacy terms and use, you want to be as holistic as possible, but you also want to be as honest. Most people will sell their data to third parties, and they be as honest and as clear as possible, but also have restrictions, right? You need to ensure that, look, put it there, that you are holding yourself accountable to standards, international standards in terms of protecting their data, and the rest of that. But yes, in answering your question, you can include that in the privacy and terms of use document. You can include that at the onset, and you can make it as expansive as possible. But it does not absolve you from where that data is used by a third party and it causes them problems. It does not absolve you of some of the obligations you have to take in terms of data protection, data privacy, especially in terms of the law. So in Canada, we have the PIPEDA Act. There are some countries in the EU that have the GDPR. There are some rules and regulations around data. I think in Nigeria now, the government is going to release very soon, which I was part of, they're going to release an AI policy document, and they have a chapter on healthcare itself. In there, they have how AI for healthcare systems should be able to use data and regulate. And they have areas you should not share people's data. People you should not share their data to and all, for commercial purposes and all. But yes, to answer your question, you can do that, but also does not mean because they've given you the yes and amen, you can go ahead with it. The second point I'd like to make is, please ensure that you are communicating in language they can understand, because those data privacy agreements, they're always small text, and they'll just say click here, but they'll make it so hard for you to read. Suppose in case, if maybe perhaps, for instance, example, e.g., it's too, make it clear and make it simple, right? And it's okay. It's not a crime to say, I'm going to use your data for research. It's not a crime to say your data might appear in other test use cases and all. It's okay. It's okay. But let them know. Don't make it look like you're trying to be smart. You should say they're wise kind of situation, right? So make it clear, make it open-ended at the beginning. And if you've included their approval to use data, but you need it for something else in the future, you can go back and ask for that. You can go back and send an email to say, look, we're going to use your data for something new again. We didn't get your permission earlier on. Can we use it now? These things will save you a lot of millions of dollars in lawsuits.
All right. I think that is the end of the questions. Thank you very much, Jake, for your insightful presentation. And thank you, our viewers, our participants, for coming, and the people that ask questions. Your questions are really, really helpful. And I guess a lot of us that into this system and all the researchers here today, we've learned a lot on how to go about, ethical issues concerning your data, both gathering the data acquisition, or you're building a model with data. And you can also consult Barrister Jake, either privately for, legal advice. He will tell you his terms, if you need to. You can get him on email. I guess your email should be on your slide. And
yes, I could also share that. But yeah, I want to see how people can develop more. I think it helps community and helps all of us if people can think of some of these values and propositions that we're making. And I believe that from the global south, we can set an example and a standard for how inclusive we want our health AI systems to operate and how our systems can serve people outside capitalistic gains and monetary like rewards. Yes, you can make money, but you can also change lives, right? So I'm happy to engage with anybody for free. Just let's build a community here so that we can develop more responsible AI systems in healthcare that will change lives of our people, because I don't think the people in the global north are designing AI systems that would meet our needs specifically. We need to be able to be critical about that. And Dr. Blessing's point about decolonization is something I'm very passionate about as well.
So thank you very much. So you can also see the recorded, this session is recorded and you can get it from the website, which is on the chat box right now. You can visit the website, visit our YouTube channel to download or play the recording again. You can also follow us on Twitter for AI for PEP Network and Cypher. You can follow us on Twitter and LinkedIn. We are all there. Then you can also email or contact Barrister Jack directly through his email, which is, I think he has shared it on the chat. If you haven't, you can share. Then I think it's also on your slide.
Yes.
And that ends it for today for us. I thank you, all of you, for coming. You can we'll likely meet in the next 2 weeks based on the approval of the organizers. We'll confirm if we're going to have, because we planned to actually end this series today with Barrister Jack. But it seems like we are getting, a lot of feedbacks that we may need to continue, because people are really enjoying and getting learning a lot from these sessions. So we would like to, you have to keep watching, and you might get an email from us confirming that we're going to have it in the next 2 weeks. From me, I will say thank you for coming, and bye for now, everyone.
Thank you very much. Bye for now.
Yeah, thank you very much for that presentation. And thank you to everybody. Thank you, Blessing, for moderating, and everyone who participated. And yeah, as you mentioned, it is technically the last session, but we're happy to continue if we can find more people to speak on this topic. Like you said, I think it's been really well received. And it's an important topic that we can definitely have more discussions on. So yeah, everybody just keep an eye out for more emails, and yeah, hopefully we'll have more sessions and continue this conversation.